Okay, guys, I'm going to start chapter 19 lecture recording. And I'm actually going to be running through this one because there's not a lot of this stuff on the exam. So I will, oh shoot, I thought sorry. There we go. All right, so I'm just going to run through this one and point out stuff that I think is significant. So here are your learning outcomes for the chapter. All right. I'm not going to run through this review because it was just pretty much in my last lecture, your respiratory system review. Okay. Your circulatory system review. So I do just want to remind you, because we haven't gone over fetal development yet, I just want to talk to you about, or remind you about the 3 shunts. So in fetal circulation, so fetal being in utero, we have that ductus arteriosus that's connected to the aorta, the foramen valley, between the atrias and the ductus venosus in the liver. Okay, so those, when the baby is born and the cord is clamped, those ducts eventually close, and when baby's born and the cord is clamped and the baby starts taking their breaths, they switch over to neonatal circulation, or basically our type of circulation. Okay. All right. So, oh my goodness. So classification of high-risk babies. So they can classify them according to gestational age. So the preterm, again, is this is a review. Preterm is before 37 weeks. Term is after 38 weeks but before 42 weeks, and post-term is after 42 weeks. Okay, they can classify high-risk babies according to their birth weight. So low birth weight is less than 2,500 grams, or up to 2,500 grams. Very low birth weight is less than 1,500 grams, and then extreme low birth weight is less than 1,000 grams. They can classify high-risk babies according to birth weight at their gestational age. So we've reviewed this, we've went over this before. Small for gestational age, so they're below the 10th percentile for their gestational age, appropriate for gestational age, and then large for gestational age, which is above the 90th percentile for their gestational age. Okay, and this is that same graph I showed you in the earlier recording about how we plot their weight with their gestational age, and see where they fall in as opposed to this 90th percentile line and this 10th percentile line. If they're below it, they're SGA. If they're above it, they're LGA, and if they're in between it, then they're AGA. Okay. Now, as far as there's another thing called intrauterine growth restriction, and there's 2 different kinds, symmetrical and asymmetrical. So we're going to start with asymmetrical, and usually when you hear the word asymmetrical, you think that's abnormal, but asymmetrical is the better of the 2. Okay. Oh my goodness, I have a typo. So this is correct, asymmetrical. So it stunts their growth and development of all their systems except their brain. So what that means is their brain and heart. So their brain, or their head, is what you would see as a normal size compared to the rest of their body. Okay, and this one that says asymmetrical, that my cursor is under, that's supposed to say symmetrical. Okay, so so the asymmetrical, the insult that causes this growth restriction happened usually later in pregnancy, when there's all these, when all their development has occurred, all the organs have been formed, and now the baby is growing. So the organs are all great, except the organs, the body organs, the growth is stunted, but the brain and heart still grow normally. Okay, so the insult wasn't that terrible, and it happened later in the pregnancy when all the organs have already been developed. That's asymmetrical. Now this one that should say symmetrical, it occurs early in the development, or when the organs are starting to develop. Okay, so this baby is, everything is affected, the brain, the heart, all the organs of the body. This happens early in pregnancy, and so therefore when all the organs have a problem, especially the brain and the heart, then this baby is going to have more problems than this baby up here. So please make that correction. This is symmetrical. This is supposed to say symmetrical. Insult occurs early in development. Okay, this is symmetrical growth restriction. Okay, I apologize for that. I should have read these. Okay. Okay, so with your SGA baby, so small for gestational age, they might have muscle wasting. So like your post-term babies that are 42 plus weeks, they might have been, good little fat little 7-pound babies at term, but because they went past term, you would think, well, they're just packing on more weight. Well, yes, a lot of times they do. But depending on the placental function, so that placenta is only designed to live for 40 weeks. So it's going to start deteriorating. And therefore, its ability to transport nutrients and oxygen to the baby are going to start deteriorating. So this baby might start losing weight or losing muscle and losing its mass. So that's why a 43-week baby could be an SGA, small for gestational size baby, is because of this muscle wasting. But anyways, SGA babies have a lack of brown fat. Their abdomens often look sunken in because they're just so skinny and old man looking. So these are kind of sometimes the appearances of these babies. We know, we've already reviewed that small for gestational babies or babies at risk can suffer from cold stress, and when they suffer from cold stress, then they have increased metabolic needs. They start using more oxygen, they start having respiratory distress, they start getting acidotic, and it's just a vicious circle. Okay, so we want to prevent cold stress, and we've already talked about that previously. Pain is another problem for could be for sick at-risk babies. Just like adults, like if a baby's having pain, you can see that in their signs and symptoms. So you can read through these signs and symptoms. But when we diagnose pain, we use a scale, an assessment scale, where we actually rate baby's pain, and I'll show. I think I can show you an example of that. But what we do to treat it is neutral thermal environment, remember? So yeah, we want to keep these babies warm, okay? We want to swaddle them. We want to decrease the environmental stimuli. We want to provide non-nutritive sucking, in other words, a pacifier, comfort, okay? And then, of course, we can give medication. So this oral sucrose solution, or what we kind of call sweeties, it's a very concentrated sucrose solution. We put a little drop in their mouth and then give them their pacifier, and it works on the pain receptors similar to the way morphine does. Okay, but if you have a baby that has serious pain issues, we can give NSAIDs, we can give opiates, sedatives, and even anesthetics if there's a severe thing going on. Now remember, these aren't just your normal term babies in the mother baby unit. These are your NICU babies, okay? So here's an example of a pain scale. Okay, it's not the one I use on newborn babies. They may use this in NICU because they have an oxygen saturation score. But so you're going to assess their gestational age and they're going to get a score. You're going to assess their behavior and they're going to get a score. You're going to assess their heart rate. They're going to get a score. Blah, 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 and further and further and further. The higher the score, you tally all these up, the higher the score, the more pain this baby is in. So your physician will have an order for pain medication if their score is this, or if their score is this, then you can give this pain medication, or if their score is higher, you can give this pain medication. Okay. We already know hypoglycemia is a problem for gestational babies because they just don't have the stores of glucose to do everything that they need to do. So they blow through their blood glucose and then they drop their blood sugar. So they go through hypoglycemia. Here's newborns at risk. See, large, I know this says SGA. I'm sorry, I should fix that. But you're large for gestational age. You're infants of diabetic mothers. Remember that these babies, large and infant of diabetic mothers, these babies were receiving lots of glucose through the placenta, okay? And the babies themselves were producing the insulin to handle that glucose load. Now, they're producing all this insulin and they're born and the cord is clamped and their glucose has been cut off. And now they're just breastfeeding, okay? So, so they can, the insulin that they're used to producing can dispose of their glucose quite quickly, and then these babies will be at risk for hypoglycemia. Here's your signs and symptoms. So they could be asymptomatic. Your baby's blood glucose, remember it, I'm sorry, this says 50 to 60. This should be 40. I'm sorry, these slides each chapter says something different and it really irritates me, but 40 to 60 is what is the range that we have, okay? Okay, where was I? So your baby's glucose could be 35 and they could be showing no symptoms at all. Or they could be jittery. Or they could be poor feeders, which they might be anyway, and they might not even have hypoglycemia. They could be cyanotic and apnea. They could be tachypnic, high-pitched or weak cry. They could have seizures, and then severe hypoglycemia that's not being detected and treated. These babies can suffer neurological damage, okay? So we do heel sticks right in the room, and anything less than 40 is treatable for our term babies and less than 50 for our high-risk babies. And then what we do to treat hypoglycemia is we feed the babies, and hopefully that solves their hypoglycemia problem. But if this is a really sick baby, like they may just go, and this baby, if this baby's in the NICU and they're very sick, this baby, they may not be feeding this baby. They may be keeping this baby NPO. And so definitely, this is the fluid of choice, D10W, okay? Dextrose in 10% dextrose in water, okay? And then this is just a picture of where we do the heel sticks. And I know this looks like it's on the bottom of the foot, but guys, if you could just concentrate on doing the corner of the foot, not up on the sides of the foot, but just that corner, that would be great. And you can do either side, okay? Polycythemia, so that's a high crit. I'm not going to go through this. You can read through this. High crits, well, I guess I am going through it, can happen for many reasons. So intrauterine hypoxia, so the baby is having decreased oxygen. So what the body does in you and me is, well, we need to produce more red blood cells so we can carry more oxygen. So we have more red blood cells to carry oxygen, so babies can become polycythemic. Okay, here are what your complications are for polycythemia. So we'll just watch H&H. So the more red blood cells you have, the more red blood cell breakdown you have. Therefore, the higher your bilirubin will be. So they'll have, we'll be watching their bilirubin levels. So what do? We feed them. We hydrate them, feed them. And if that's not good enough, we do IV fluids. And then in extreme cases, we might do an exchange transfusion. So conditions affecting large for gestational age babies. So these are just babies that are just beefy for no other reason, or babies born of diabetic mothers. Okay, so like I said, they're getting all of mom's glucose, and then the baby is producing the insulin for it. And then the baby is born, we cut the cord, the baby isn't getting the glucose anymore, and so so then babies can be at risk for hypoglycemia. So this says chronic hyperglycemia state in utero. So don't get that confused. This is what baby's having in utero. Lots of glucose from mom, okay? But then when baby's born, it's hypoglycemia. All right, transient tachypnea of the newborn. So that is just a fancy way of saying, you know, the lung fluids that's normal for babies to have. So instead of getting most of that squeezed out or absorbed, they have some lingering lung fluid, okay? And then that will cause transient tachypnea. So babies will start breathing faster so they can breathe in more oxygen, because there's that fluid there that's getting in the way of oxygen exchange. So they breathe faster. And it's transient, okay? So that means as soon as babies can get that fluid off their lung, then they're absolutely fine. Here's your babies that are at risk for that. Here's your signs and symptoms. Of course, tachypnea, it's in the name. They might have grunting and retractions. Remember, I talked about those as being signs of, and nasal flaring being signs of respiratory distress. Grunting is that sweet singing sound mama tells you about. Retractions is when they're sucking in the skin between their ribs, below their ribs, above their sternum, below their sternum, above their clavicles. Okay, and then cyanosis and nasal flaring, of course we talked about that. And then cyanosis this is central cyanosis. This is not acrocyanosis. So this is their mucous membranes, their lips, things like that, okay? We can diagnose it on chest x-ray. Sometimes that's all they'll do, is they'll do a chest x-ray, they'll see that they have some fluid, and they won't do this blood gas, okay? But if this is severe enough where babies are on CPAP, continuous positive airway pressure, they might start doing blood glucoses, okay? But a lot of times if these babies are just on supplemental oxygen, a chest x-ray would be sufficient. We do want to hold feeds. Why do we want to hold feeds? Because if you're breathing so fast, how can you swallow, okay? And if you're breathing so fast and having such a hard time oxygenating, why do you want a full belly pushing up on your diaphragm, okay? So we hold feeds, and then we let the babies work this out. If we have to, if they're, you know, sometimes these babies transition in a couple hours. Sometimes it takes them a couple of days. So if we're holding feeds, we might be wanting to do some D10W for these babies to maintain their blood sugars. Okay, and then they transition out of this, and they're perfectly normal, happy babies. So here's just a picture of what some of these retractions look like. Nasal flaring, we're trying to show you, this is none. Now see how big this baby's nose is, and then this is supposed to be even bigger. Okay, so that's flaring, all right? Grunting, this is not a good picture of grunting because you have to hear grunting. But this shows you retractions, okay? These show you retractions. And then this is very difficult to assess. But you could see this especially in your NICU babies, where they're breathing, the way they're breathing is, so this is normal, so they take a breath in, they take a breath out, okay? But here they're doing it like this part of their chest and their abdomen are taking a breath in, and this part of the abdomen was blowing out, so you get the picture there. Hypocalcemia, hypomagnesemia, I'm not going to go over, you can read those slides, but I do want to talk real quick about birth injuries. So we have neurological injuries and bone fractures. So these are from the actual birth trauma, okay? So your neurological injuries kind of fall in this brachial plexus injury category. So the nerves of the brachial plexus are either stretched or damaged in some way, and they leave that arm without function for a period of time. Okay, so these are just showing you what part of the cervical spine spinal cord they're coming off of, C5 through T1. That's just a stretching injury. This Duchenne's Erb's palsy, a paralysis, is the nerves coming off of C5 and C8 have been damaged. Klumpke's paralysis, the nerves are coming off C8 to T1. Your baby's at risk, so you're large for gestational age, can you imagine? Or macrosomy. Macrosomy is a large baby. You can imagine that they might have some trauma coming through that birth canal. Newborns of diabetic mothers because they're big babies. Babies from an instrumented delivery because we're basically pulling those babies out. Prolonged labor, a shoulder dystocia, so the shoulder gets hung up on the pelvic bone, and we have to do our maneuvers to collapse that shoulder. Anyways, signs and symptoms is no movement of that arm, elbow, or wrist, okay, or hand. And then one way you can assess for it is when you do your Moro reflex test, like when you open the blanket and the baby startles, the one arm doesn't move, but the other one does, okay? So we do our neuro assessment. We can do some diagnostic imaging tests, but the treatment basically is to rest the arm, okay? We can do passive range of motion after about the 5th, from days 5 to 10. We can start doing tactile stimulation, and if it's severe enough, they might need to do surgery, okay? So fractures, the clavicle is the bone that's most at risk for injury, but we can have long bone injuries as well. So clavicle fractures, so I do assess those. Oh, here's your at risk for pretty much the same as the brachial plexus injuries, large babies, instrument delivery, steroidal dystocia. Here's your signs. Then you won't have movement of that arm or very limited movement. There'll be swelling of the clavicle, pain with palpation or pain all the time. And when you palpate, you can feel that crepitus or creaking, okay? Treatment is immobilization, pain medication, and then it heals, okay? Premature newborn, so there's classifications of premature newborn depending on their gestational age. So your late preterm baby. So this is your baby from 34 to 37 weeks. All these babies are preterm, but the severity of their complications, it's kind of grouped into categories of their birth age. So they have less problems at late preterm. As a matter of fact, they might not have any problems at all. But anyways, 34 to 37 weeks is late preterm. Moderate preterm is 26 to 34, and severe preterm, or what you might call micro-preemies, is 23 to 26. So in this range, especially around the 23-24 week zone, is viability issues, okay? All right. So this is just assessment. So you can look at these pages to look at this assessment, which is very similar just to the normal newborn, okay? Respiratory distress syndrome, we've kind of reviewed that a little bit. That's a surfactant issue, a lack of surfactant for whatever reason. Diffuse atelectasis, so parts of the lung can't expand, or those little alveoli have too much pressure on them to take an inspiration after expiration, okay? So you can hear that, those crackles or edema in their chest. Signs and symptoms, so we're going to have all these respiratory distress symptoms. So we're going to be maintaining their airway, we're going to be oxygenating them, and then we're going to be giving them surfactant, okay, through the ET tube. Continuing with respiratory distress syndrome care is, airway maintenance, oxygenation is the priority. So our oxygen is going to be humidified. We may be doing a CPAP, so this is continuous positive airway pressure. Maybe a mask that goes on the baby that provides that. We could be doing mechanical ventilators, high frequency oscillation, these things. To be perfectly honest, high frequency oscillation, nitric oxide, and this extracorporeal membrane oxygenation, or ECMO, those are beyond me, okay? These are high-level NICUs, and I've worked in NICU, but I have not worked in a high-level NICU. So I do know of these things, but I don't know a lot of specifics. So that's something that if you're interested in, you can check with during your NICU rotations about those things, okay? All right. Apnea of prematurity. So remember when I told you earlier, apnea is, so babies have, the babies can have periodic pauses in their breathing. If it's over 20 seconds, it's not a periodic pause. It's apnea, and those are not good, okay? So if it's a primary apnea, you can stimulate the baby to start breathing again, but if it's a secondary apnea, you're going to have to probably do some sort of ventilation to get baby breathing again, okay? Here's your signs of apnea. If counting respirations and not having one for greater than 20 seconds is not a good enough sign, then you're going to see these other things right here, okay? So if babies have periods of apnea, we put them on a cardiorespiratory monitor that will alarm if they stop breathing for more than 20 seconds, okay? We'll have them on continuous oxygen pulse oximetry reading. There's things called, we call it A's and B's, apneas and bradycardias. So they usually go together. And so your cardiac monitor will alert you to those. So, so here is medications that can be given to babies who struggle with apneic episodes. Okay, bronchopulmonary dysplasia or chronic lung disease. I'm going to kind of let you read through this. So some of these lung problems, there's different names for really kind of different things. But we, our main thing is oxygenation, watching our baby's respiratory rate or their oxygen saturations, and keeping them breathing, and maybe holding feeds till we get the breathing issues under control, so things like that. So we've talked about jaundice. I'm not going to go through this again. Here's that graph, like I told you I'd show you when we're in clinicals. So I told you that we take that their bilirubin levels. So say our baby had a bilirubin level of 5, and they were 24 hours old. We would plot them right there, and we can see that they're in the either low, intermediate, or low risk zone. Okay, and then if we tested that, okay, so let's do another number. So let's do 10. Let's do 10. Okay. So if we had a baby that scored a 10, if we had a baby score a 10 at 24 hours old, and I was right, 95 percentile, any babies over this 95 percentile line, they get treated, okay, with Billy lights. But we tested our baby. Our baby was 10 at 24 hours old. So that makes that baby in this red zone, which is the above 95 percentile zone. This baby is going to be treated with lights. If we tested that baby in another 12 hours and baby was still 10, look, now we're in this, now we're below the 95th percentile, and we might take the baby out of the lights now. And then we might test baby again. And look, if baby stays 10, look how low risk baby starts becoming as baby ages. Okay, so that's kind of what I wanted to show you. All right, so we talked about what we do, frequent and early feedings. If babies if they're in that 95% zone, they're going to get phototherapy. We put them under the lights, and now what we're using, and I say put them under lights, that's the way we've always done it. But we have Billy blankets now, so it has the light in the blanket, and we wrap the baby in the blanket. We still want to cover the baby's eyes, though. And we always have a diaper on the baby, and we hydrate with electrolyte solution. So this is a really high jaundice level. Hopefully we only need to feed the baby, but if the baby's high enough, we might have to use IV solutions. Okay, and then remember, if the baby's levels are too high and we need to do an exchange transfusion because we're worried about the levels being so high that it might cause brain damage, this is what that would look like. This is what that setup would look like, the exchange transfusion. Okay? All right. Oh, well, click the button again. Bilirubin encephalopathy, so anything enceph means brain, so we have permanent brain damage here. Well, we have, the brain has been affected. I'm sorry, okay? The brain has been affected, and we might be able to pull the baby out of this. But if kernicterus sets in, then it's permanent brain damage, okay? We can't change the damage that we have caused. It's permanent, okay? All right. Anemia, I'm going to let you read through this. I'm not going to go over this very much. Necrotizing enterocolitis, so we've kind of went over this a little bit. Here's your signs and symptoms. So no bowel movements, abdominal distension. So we want to start doing abdominal circumferences, measuring the baby's belly girth. They're irritable or they're lethargic, and we could actually see loops of bowel. But that is like a very progressed sign. We can do x-rays. We can do our lab studies. But our care is like they're going to be NPO. We're going to keep doing our abdominal circumferences. We're going to keep auscultate bowel sounds before feeds. So we're not going to feed a babe who has neck, okay? Anyways, so if they have necrotizing enterocolitis, they're probably going to end up having surgery to have the necrotizing bowel portion removed, okay? So maybe this is, definitely what we would be doing after surgery when the baby has recovered and we can start feeding again, okay? We'll put a gastric tube down to keep... okay. So if we have a gastric tube down on a baby, that, let's say the baby doesn't have neck, okay? Any baby that we have a gastric tube down in order to feed, we're going to check the residual volumes in their gut, okay? And if we're feeding every 2 hours and we have undigested food in the belly after 2 hours, then we might be having a problem, okay? But for a baby with necrotizing enterocolitis, they may, until they're treated and recovering, they may have an NG tube down or an OG tube down to keep on suction, to keep stuff out of their bowel from moving, out of their stomach from moving through their bowel, okay? Of course, we're going to record all bowel movements when they start having those again, and we may even hemocult the stools to test for fecal blood, okay? They'll be NPO for 13 to 14 days. They're going to have that NG tube I was telling you about to decompress the abdomen, and so it'll be on suction, probably intermittent suction to keep everything out of the gut. They'll be on antibiotics. We'll put them on lipid peripheral TPN and lipids for their nutrition. And then do post-surgical care as if we were doing it on an adult. So we'll be taking care of their wound, okay? Some of these babies will end up with an ostomy until they're fully recovered, and they may go home with an ostomy. So we will need to be teaching that care to the parents. Gastric reflux, I'm going to go ahead and let you read about that. A lot of term healthy babies have gastric reflux problems, even breastfed ones. Matter of fact, the two that I am personally involved with are breastfed babies. I mean personally involved with, they're part of my family, okay? Sorry, so that's TMI. And they're breastfed babies. But anyways, you can read on GERD, okay? Retinopathy of prematurity. So this is a risk for prolonged oxygen use, actually. So we're worried about damage to their vasculature in their eyes, causing retinal damage and blindness. Okay, so I'm going to let you go ahead and read up on that. Okay, so we want to use as little oxygen as possible in these babies. To prevent retinopathy of prematurity. Intracranial hemorrhages, I'm going to let you read. There's not, so I'm going to let you read it. So there's not a lot about it, okay, on the exam. Post-term babies, you would think, well, they shouldn't have any problems. Well, they could have a lot of problems. So these are babies born after 42 weeks. They can be large for gestational age, like I told you, or they could have wasting syndrome, okay, and meconium problems because they probably had meconium in utero. So your clinical signs is meconium stained cord, peeling skin, like it's been in the water too long, and so it'll be peeling, or parchment-like skin, cracked. Fingers appear long and peeling, or general wasting appearance. Okay, so these babies will have glucose issues. They'll have thermia issues. They may have feeding intolerances. So these babies aren't just like big healthy 3-month-old babies. These babies could potentially have lots of problems. Okay, so here are some of those problems. Meconium aspiration syndrome. So any baby that has had meconium in utero is at risk for meconium aspiration syndrome. That meconium, so they inhale that in, and of course it's a huge obstruction. It's thick, tarry stuff, meconium is. So they have that thick, tarry stuff in their lungs. So these babies are in serious trouble, okay? So they could have persistent pulmonary hypertension, so that's kind of related to the pulmonary vasculature. Still has a lot of resistance and pressure in it, where it was supposed to, like the healthy newborn, we were supposed to reduce our pressures in the pulmonary vasculature, so that we could start sending blood over there to get oxygenated. They might have a pneumothorax, or air in the spaces surrounding the lungs. They can have all kinds of problems, okay? Here's your signs and symptoms for that. Another thing is they breathe in meconium, and meconium will denature surfactant, so make surfactant not work, okay? So there's that problem. We do a chest x-ray, and then these babies are in the hospital for a long time. So they have a lot of chest therapy. They're on oxygen. They're on medications. They're on pain medications, sedatives to keep them quiet. So a lot of stuff. So persistent pulmonary hypertension of the newborn. So this is that deal, persistent fetal circulation, where those ducts don't close and the pulmonary vasculature remains high, the pressures remain high instead of them dropping for the newborn circulation, okay? So they're not getting a lot of oxygenated blood is what's happening here, okay? So these babies are also in severe problems, okay? So they'll develop respiratory distress, and they'll need to, here's your signs and symptoms. So clinical signs, so we need to oxygenate these babies. These babies need all the oxygen that we can possibly get them. And the nitric oxide will start dilating their pulmonary vasculature. And then they may need to be on ECMO, and then I don't know how to take care of them. Newborn screening, so I talked about this during the 24-hour cares we do on normal newborns. They check a lot of disorders of the babies. So metabolic disorders like phenylketonuria or PKU, hematologic disorders, endocrine disorders. So we do this blood, we get these blood samples on. So basically there's this paper, funny looking paper, and it has 5 little circles on it. And we fill those circles up with the baby's blood, and then we send this to the state, and then they test the baby, okay? Um, so if the babies have like PKU, a problem, so that is an inability to convert the amino acid phenylalanine, you know what I'm saying. They can't convert that, so they have to be on a special phenylalanine-free diet, okay, for the rest of their life. This doesn't go away. Okay, galactosemia, so they can't metabolize galactose, so they are on the special galactose-free diet, and that's a lifelong thing. Maple syrup urine disease and homocystinuria, I'll let you read about that. Biotinidase deficiency, I'll let you read about that. Congenital hypothyroidism, so what is that, right? It's a lack of thyroid hormone, of course. So here's your signs and symptoms, and don't they look like a lot of like everything else that we've been learning about almost? So here's your diagnostic studies of your the labs that will run T4 and T3, and then these babies will be treated with Synthroid. Okay, spina bifida, those neurotube defects that we were talking about. One big prevention of those is for mom to be on folic acid supplements, and sometimes depending. Well, we start them on the folic acid supplements when they come in, but if they had any pre-pregnancy counseling, they'll start that before they even get pregnant, okay? So anencephaly, we already discussed that one. That's where they have missing parts of their brain and parts of their skull incompatible with life. Anencephaly, okay? Encephalocele, okay? Encephalocele, so when you see the word seal, you're thinking of a sac, basically. So there's a protrusion of the brain through the skull, okay? So when these babies are born, we cover that defect with warm, sterile gauze until we keep it covered, depending on how long, until they can have surgery, okay? Not good for these kids, okay? Microcephaly, so you've probably heard about this on the news, where their brain and their head are smaller than it should be for them. So they'll have some delays. I mean, they can live, but they'll have some developmental delays, and depending on the severity of it depends on whatever. So anyways, so this holoprosencephaly, I really don't know a whole lot about. I've never taken care of a baby with this. So they do have, the brain, parts of the brain aren't formed right, okay? So these babies don't end up making it, okay? Cleft lip, cleft palate, or both. So they could have a cleft lip, or they could have a cleft palate, or they could have both. So this is where their palates are not formed completely, okay? These can be surgically repaired. If it's minor, this child may grow and people may never know they had this as a child. Or it could be so severe that they have, that surgery can only do what it can do, and they may have some, scarring or speech impediments that may clue someone in. But anyways, so they can have a unilateral cleft lip or a bilateral cleft lip. So only one side of the lip is on the unilateral, only one side of the lip is partially not formed, or the bilateral is on both sides of the lip. It's partially not formed, okay? So depending on the severity and depending on if the palate is involved, we need to make sure these babies can eat. So breastfeeding, depending on how severe, is possible. If it's not a terrible severe and they can create a latch with suction, that's great. Then we can breastfeed them. But these babies may need to wait until they're surgically repaired before they can breastfeed. And if that's the case, these women need to be pumping, okay? But usually these babies are bottle fed. especially if they have a severe cleft of some sort. There's a special nipple that you can use, but it helps it helps fill in that cleft, and then it helps prevent them from getting a mouthful of food that they can't swallow right. So we need to feed in the upright position, and teach the parents how to do this until they get their surgical repair. So congenital diaphragmatic hernia, I did mention this. This is where the abdominal wall, it's an abdominal wall defect. So the bowel actually spills into the lung, and it's usually on the left side. So these babies have, when they're born, they have severe respiratory distress problems. Here's your signs and symptoms. The barrel chest is because their chest is full of one lung, a heart, and a small lung and bowel. Okay, so the chest looks like this big old barrel, and then there just looks like there's nothing in the abdomen, so it's like sunken in type. So they call that a scaphoid abdomen. Okay, we can see this prenatally on ultrasound. So when these babies are born, we need to manage their airway. They're going to be NPO, so they're going to have, and then they're going to have an NG tube down to decompress the stomach. They might even be on ECMO, and then they're going to need surgery. Okay, so gastroschisis and the omphalocele, we've already talked about gastroschisis. Remember, that is the where they have the defect in the abdominal wall, where the intestines spill out onto the outside of the body, and they're just laying there, like their intestines are just laying there. The omphalocele is when it protrudes into the umbilical cord area, and it comes through the umbilical cord, and it's encased in the umbilical cord area. Okay, these people need surgery as well. We'll keep NG tube down. I'm sorry, I'm getting ahead of myself. Okay, signs and symptoms. Signs and symptoms. You see this, like when they're born, it's laying there. You see it. Okay, so we keep the contents covered with sterile moist gauze. Position. We position the intestines above the level of the defect, because we don't want things draining from the top of the body down through the defect into that bowel. We want to keep that above. We'll put an OG tube or an NG tube down. They'll be on fluids, maybe even on TPN. They're going to have antibiotics. They're going to have surgery, and so then we're going to need to do post-surgical care on these kiddos too. Okay, babies with herpes that got transmitted usually during vaginal delivery. Here's your signs and symptoms. We can diagnose. Here's what we use to diagnose. And so these babies are on acyclovir for the first 2 weeks of life, and then, of course, forever for life when they need to. It's just like an adult. Sepsis or systemic infection in the baby. Here's your signs and symptoms for those. Hypothermia, lethargy, hypoglycemia, poor feeding, respiratory problems. Those are really related to just about everything. So it really makes it kind of hard to figure out what things are. But you can understand, as I talked about, it's kind of a vicious circle. You have a baby who's stressed about something, then they're going to use up their glucose stores. They're going to drop their temperature because they're working so hard. Then they start having breathing issues. So it's just a vicious circle, okay? So, of course, we're going to do a CBC with DIF. We're going to do a C-reactive protein that tells us if a baby's fighting infection. We're going to look at baby's platelets. We're going to do a culture. We may even do a spinal tap. Okay. So our nursing care for a baby with infection, of course, is, monitor INO. These babies are going to have IVs. We're going to be giving antibiotics. We're going to be monitoring their cardiorespiratory status, okay? And we're going to do everything we can to minimize our baby's expenditure and just let our baby rest. Neonatal abstinence syndrome, so we're going to see this a lot, okay? So this is a baby of an infant of a drug-abusing mom. So we can test mom's urine when she's in labor, and then we also do a cord stat. So we collect a section of baby's umbilical cord, and we send that for drug screening. We used to always do meconium drug screening. So their first meconium stool, we would collect and send that for drug screening. But now we always test mom's urine, and we always do a cord stat. Okay. Signs and symptoms of withdrawal. I want you to look at page 747, big box there. Jitteriness, fussiness, stuffiness in the nose, sweating, diaper rash, irritability. There's a whole slew of symptoms on there for you to look at. Okay. So of course we're going to try to keep these babies as quiet and calm as possible, but these babies are screaming their head off almost 24/7. So we just do our best to soothe these babies as best we can. There is a thing called a neonatal abstinence scoring tool that has assessment parameters that they have things that they want us to assess on baby every 3 hours, and then we put our assessment answers in there, and then the babies get a score, okay? And depending on their score, will indicate what kind of withdrawal medication regimen we're going to put these babies on, okay? And you can see, look on page 747 and see the medications we use for these babies, okay? Sudden infant death syndrome, I'm not going to read through this except to say that we educate our patients, well, I guess I'm going to read through it. We educate our patients on prevention, okay? And the biggest one right here, back to sleep every time, okay? Babies need to be on their back when they're sleeping. A firm mattress, no stuffed animals or fluffy things in their mattress with them, okay? We want the newborn can be in the parent's room, but we do not want them in the parent's bed. Loose bedding, we don't want in the crib. Of course, smoking. They're doing some studies where the use of a pacifier might decrease the incidence of SIDS, and then not letting the baby get overheated, so not so many blankets, okay? So for high-risk babies, irregardless, thorough assessments, head-to-toe assessments, frequent vital signs, which include babies at high risk in the NICU are going to have blood pressures and continuous pulse oximetry readings, and they are going to, well, we do a pain assessment even on normal term newborns, but our pain assessment thing is a little different from the pain assessment that they use in NICU because they have some other parameters that they look at. But nutrition is a big thing for these babies because they might be on intravenous feedings like TPN of some sort. We might be doing bottle feedings and breastfeedings. We might be doing tube feedings. And we let the babies have pacifiers in the NICU, okay? We don't like to have pacifiers on the normal newborn area, but for sick babies, you can have it, honey. We do watch their INO. Of course, we can measure everything we put in that baby, like IV fluids and feedings, and we can even measure their output. So we can weigh their diapers. 1 gram equals 1 cc, okay? And then we're going to be taking care of these babies' skins. They have a lot of fluff stuff that they use. They have a lot of propping that they use in the NICU. This is different than a baby in a crib at home, okay? They have constant supervision, so they do a lot of things. They turn babies a lot. They reposition probes and all kinds of things to take care of their skin. Developmentally, we want to keep the noise down. We want to keep the lights down. We may even restrict handling of the baby, okay? We really need to work with the parents in the NICU. They're part of the team. We need them to participate and be on board with our cares. We encourage them to participate in as much of the cares as we're providing. Now, I told you I used to work in the NICU. I don't have my water and I'm getting really yucky here. But they do classify level of care of NICUs. So level 1 is a normal newborn normal newborn area, so we don't have nurseries. But the mother-baby unit at CMC is a well newborn level 1 area. And if we had to, we are trained and capable of stabilizing high-risk babies, but only because we're waiting for transport. Okay? I've worked in that level of newborn care. And level 2, where's my cursor? Level 2, I've worked in this level of newborn care. And this one, we can give oxygen and start IVs and do IV therapy and give antibiotics and all those kind of things in this level. In level 3, basically, these babies are super sick, ventilated babies. All right? Now, these level 2 babies can be in a level 3 unit. I'm just saying that we are not a level 2 nursery or neonatal care unit is not capable of providing this level of care. So that's what the difference is, okay? All right, so transporting baby. So every hospital that has a baby born there, whether on accident or not, needs to be capable of stabilizing that baby for transport. And there is a competency program which OB nurses do every 2 years. It's called STABLE. It's the STABLE program. OB nurses in every level of OB delivery should be taking this program, because this program teaches us how to stabilize the babies until transport gets there. And the chapters are broken up into this, so that STABLE is a mnemonic: sugar, temperature, airway, blood pressure, lab work, emotional support. So these are the things that we need to address on these babies and stabilize on these babies and manage on these babies until transport gets there. And then discharge teaching. So when we have a baby in NICU, so discharge teaching starts as soon as they are admitted, basically. And it covers all these areas that we need to make sure that the parents are capable of caring for these children, these babies, after they go home. Okay, so I think this is the end of my lecture. So we're going to go ahead and plan for you guys to take the test as regularly scheduled.